Welcome, everyone. I'm really looking forward to tonight and what we'll be what we'll be covering. I'd also like to begin by acknowledging the traditional custodians of country throughout Western New South Wales and their connections to land, water, and community. I pay respect to the elders, past, present, and future, and extend that respect and a warm welcome to First Nations people present today. I'm on Wiradjuri land, as probably most of us, I think. I'd like to introduce to you our panellists. Dr. Manoli Abisakira, who's an endocrinologist at the hospital in Orange. Alex Hoyle, I'm taking his place tonight because he's an apology. Alison Amor, who's a credentialed diabetes educator. And Amanda Taylor, who's a pharmacist and a credentialed diabetes educator. So we've got some announcements and housekeeping. If you can keep on your webcam, we'd appreciate it. It just makes it we're more connected. But you could remain on mute except when you're speaking. We'll be recording the session, just so you know, and a reminder to maintain patient confidentiality where we will have a case. Questions are welcome, so there'll be good opportunities for you to participate, and I'll prompt as we go through so that we can keep moving. Feel free to put your questions in the chat as well. Just a reminder, if you've been coming to these sessions, the echo sessions, you probably will have got this nice and clearly, and that's really good. It's been good for me. And of course, the words that we use in talking about diabetes affect people, real people, their physical and their emotional health. They also affect how people in society view those people living with diabetes. They can show that we care, and they can help remove biases or a sense of blame or guilt. People with diabetes sometimes call themselves diabetics, so why shouldn't we? Well, there's some evidence, as you probably know, that shows 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. So some people are uncomfortable with it. And people with diabetes are free to use whatever words they wish, but people like us in healthcare have got a responsibility to engage with people in positive and helpful and respectful ways. So we've got a didactic, and I'm really looking forward to this. I've been to the last 2, but not to this Australasian Diabetes Congress, and it's great to have a summary of it, an update of what's particularly important by Dr. Manoli Abisakira. So thank you very much, Manoli.
Thank you. So I will just share my slides. Can you see that?
Yes.
Excellent, great. So today my topic was updates from the Australian Diabetes Congress, which was a conference that was held in the Gold Coast in August of this year. I only get 10 minutes, so I decided to choose the talk that I found really probably the most insightful and the most I think it was just a really important talk, and I thought I would talk in more detail about that specific issue. And I've just used a few resources just to help to put together this case and make it a bit more relevant to our communities as well. The actual title of the talk was Diabetes in Asia, and it was presented by Professor Ronald Ma, who is from the Chinese University of Hong Kong. The actual topic itself was really on young onset type 2 diabetes. And it's an area that we're getting more research on and really recognizing this entity as something on its own. So young onset type 2 diabetes is defined as a diagnosis made prior to the age of 40 years. And that's different to youth onset diabetes, where the diagnosis is made prior to the age of 20 years. The key features of young onset type 2 diabetes is that it is increasing in incidence and prevalence globally. In Australia, over the last 10 years, there has been a 44% increase in diagnoses of diabetes between the ages of 21 and 39 years, and a 17% increase in those diagnosed before the age of 20 years, which I just thought was staggering. The young onset type 2 diabetes disproportionately affects ethnic minorities, including Indigenous Australians. Indigenous youth communities have one of the world's highest rates of youth onset type 2 diabetes, and it's estimated that there is a 6 times increased likelihood of developing type 2 diabetes than in their non-Indigenous counterparts. The prevalence of youth onset type 2 diabetes in those aged 15 to 24 years has doubled in the last 5 years. And the really crucial thing about young onset type 2 diabetes is that it has a worse prognosis than later onset type 2 diabetes. There's an increased burden of complications, including cardiovascular disease, end-stage kidney failure, as well as premature mortality. And again, another staggering comparison is that early onset diabetes diagnosed around the age of 30 years is actually associated with an approximate 15-year lower life expectancy than someone without diabetes. Now, in terms of risk factors, one of the biggest risk factors is obesity, and the rising rates of obesity mirror that with the rise in young onset type 2 diabetes. There are dietary factors, so we know that sugar-sweetened beverages increase the risk of cardiometabolic diseases, and there are high consumptions of refined carbohydrates, added sugars, animal source foods and processed foods in a Western diet, which are also contributing to the rise in the rates of young onset type 2 diabetes. There is a strong genetic component as well, and most patients with young onset type 2 diabetes have a family history of type 2 diabetes. And interestingly, the greater the number of family members with type 2 diabetes, the lower the age of developing young onset type 2 diabetes. Now, other risk factors are maternal diabetes and obesity, and there is an increased risk of youth onset type 2 diabetes in the offspring of mothers who have diabetes and obesity by 5.7 and 2.8 fold respectively. And another interesting factor is that the offspring of mothers with young onset type 2 diabetes have lower beta cell function than if the father had young onset type 2 diabetes. Another risk factor for young onset type 2 diabetes is actually intrauterine growth restriction, and that's thought to be due to the development of a thrifty phenotype where there is high insulin resistance and fat storage almost as a compensatory mechanism, and that increases the risks of developing young onset type 2 diabetes. Metabolic dysfunction associated fatty liver disease or MAFLD also increases the risk of young onset type 2 diabetes, and there's a stronger association than in older patients. And there may also be a role for environmental exposures, including endocrine disruptor chemicals that are also being investigated at the moment. Now, in terms of how we get to young onset type 2 diabetes, there is ultimately inadequate insulin secretion. And one of the key features is that there is a significantly lower insulin sensitivity in those with young onset type 2 diabetes than later onset type 2 diabetes. There's ectopic fat deposition, including visceral and hepatic lipids, and inflammation in the setting of obesity, and glucolipotoxicity, which effectively is referring to the injury to the beta cells and eventual destruction in the setting of high sugars and free fatty acids. There is a more rapid decline in beta cell function with young onset type 2 diabetes. The annual decline in beta cell function is 20 to 35% in youth onset type 2 diabetes compared to 7 to 11% in adult onset type 2 diabetes. There is also high insulin resistance in youth onset type 2 diabetes than in adults, and that's thought to be in part due to the hormonal changes during puberty and high prevalence of obesity. And interestingly, there are also ethnic disparities in terms of body composition. For example, in South Asian populations, there are higher central, hepatic, visceral, and intramuscular fat deposits and lower muscle mass at any BMI. And that then leads to impaired insulin sensitivity and earlier beta cell exhaustion. Now, in terms of the real unique challenges that come with young onset type 2 diabetes, as I mentioned before, really the real crux of it is that it's associated with a worse prognosis. And there are high risks of diabetes related complications due to the longer duration of disease. This population is less likely to be screened, and they often have higher glycemic indices at the time of diagnosis than in older adults who are diagnosed with type 2 diabetes. There's also, interestingly, a blunted response to glucose lowering therapies. There's more likely to be reduced medication adherence. This cohort is less likely to achieve target glycemic control. They're less likely to be on organ protective medications and have lower attainment of blood pressure and cholesterol goals. And then there's reproductive considerations. So, younger women who become pregnant with type 2 diabetes will have higher risk pregnancies. There's also the implications for sexual dysfunction and psychosocial challenges, and there's high prevalence of diabetes distress, depression, and anxiety in young onset type 2 diabetes compared to later onset type 2 diabetes. And there's actually higher rates of admissions for psychological reasons. And of course, in this cohort, there's going to be competing priorities, jobs, families, social commitments, and that's going to really overlay the management side of things for us as health practitioners. So in terms of implications for us as health practitioners, what do we need to do? We need to recognise the difference between young onset type 2 diabetes compared to older onset type 2 diabetes in terms of the pathophysiology, its aggressive clinical course, the increased risk of complications, and the shortened life expectancy that comes with this diagnosis as well. We need to provide timely assessment and management, and importantly, ongoing surveillance. Be aware of at-risk ethnicities, including Indigenous Australians, have intensive control of the cardiometabolic risk factors, and aggressively also improve weight where this is an issue. The 2025 Australian Diabetes Association have released some guidelines, and they recommend aiming for a HbA1c of less than 6.5% in youth onset type 2 diabetes. But really, at the moment, the younger individual cohort, they're less represented in clinical trials, and so we really have a lower evidence base to guide treatment. But that's a space that is actually being looked into a lot more, and hopefully, in going forward into the future, we'll have more evidence specifically in this cohort to guide our treatment decisions. And these are the references that I used to supplement the talk from the Diabetes Congress.
Wow. Thank you very much, Manoli. It sounds very serious and a good insight for us. We've got a little bit of time for questions, if any of you would like to ask Manoli questions about this. All right. Well, thank you very much, Manoli. Thanks for putting the effort in preparing the presentation and for the insights that you've given to us.
Yeah.
It's a bit scary.
Yes. I found that quite scary too. And the reason that the title was Diabetes in Asia is that it's a particular issue in terms of that rising incidence and prevalence in Asia. So there's a lot of research that that group in Hong Kong actually doing in this space. But it's an issue that's relevant for globally, really.
Yeah. Yes. We'll move on to the patient case presentation. Amanda Taylor's kindly offered to present a case that looks like a really good one for us to consider. Amanda's a pharmacist and a credentialed diabetic educator with Marathon Health in Dubbo. And so I'll hand over to you, Amanda. Thank you.
Thanks, Martin. And thanks, Manoli, for sharing about that youth onset diabetes. I didn't have a question, so I didn't put it up. But I think that we're starting to see a lot more in practice already, which is very, very scary that that's happening.
Thank you, Alison. And thank you again, Manoli, for the didactic with the case or the sort of the subject from the Australasian Diabetes Congress. And Amanda, I found it interesting that you kept that big win that you've had more recently secret from us until near the end, but it's nice to hear.
Got to have something to hold people on.
And yeah, again, thanks for all of the participants and for your some really good insights from you as well. So that's the end. We'll just keep if the people on the panel can stay online, that would be great. Thank you. Have a good evening, everybody. Oh, the next echo we need to tell you about is November the 13th. And Eliza Whiteley will be speaking on type 2 diabetes and eye disease. Yeah, thank you and good night.
Good night.
Thank you.
Thanks, everyone.